Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you for the kind intro. I'm Reema. I am so very lucky to spend this year learning a lot about the two parts of internal medicine that give me a lot of joy, taking care of our older adults and learning more about the really special population of those living with HIV. So without further ado, I'm going to jump in. I have no conflicts of interest. Skip right over. Thank you for having me as part of this slide. And then I'm hoping that this kind of fires everybody up. I think we're all seeing in our different locations that our population in general is aging, and this is also true for people living with HIV. More than 40% of people across the US living with HIV are older than 55. I did the math for our Madison clinic, and our numbers are very similar. We have over 1,200 people above the age of 55 in our clinic. I think it'll come as no surprise that these patients, older adults in general, suffer a disproportionate amount of harm while in the care of our healthcare systems. And then the more marginalized community Venn diagrams that you have, the more negative outcomes are likely to happen. Thankfully, there's a lot of really incredible, hardworking people that are thinking a lot about this. One instance is the John A. Hartford Foundation, the Institute for Healthcare Improvement, developed a model in 2017 that tried to make age-friendly care particularly accessible to people who aren't specifically trained in geriatric medicine. Our very catchy title is the 4 M's, and it follows an essential set of evidence-based practices. Our overall goal is to cause no harm and align our care with what matters most to our patients and their care families. And this is really an exciting time to be given this talk because age-friendly health systems is becoming a buzzword that hospital systems across the country are striving to be certified as. And so my QI project in Madison Clinic is to certify our clinic as one of these age-friendly sites. And basically all that means is proving to the powers that be behind these foundations that we are thinking about the 4 M's framework and having it drive our care. And so I really hope what you take away from this slide is that I'm not really asking you to do things beyond that. You're already taking excellent care of your patients. I feel like the harm reduction mentality that is so near and dear to our hearts fits very nicely with the 4 M's framework. The 4 M's that I keep alluding to are mobility, mentation, medication, and those three are in service of what matters most to our patients. And so making sure that what brings them joy, what their worries about are being specifically addressed, and making sure that our mobility goals and the medications we're prescribing are again in service of what matters most to them. Today we'll talk about mobility, and as Dr. Wood mentioned, hopefully I'll get the opportunity to talk to you about the other three as well in the future. So today we'll talk about the prevalence and financial burden of falls and related injuries. I hope to show you that this is a particularly important topic in the patients that we are taking care of with HIV. I'm going to give you a glimpse into how geriatricians think about fall risk and how we manage these in dedicated fall prevention clinics, and how to adopt a lot of these elements into your daily practice. A pet peeve of geriatricians everywhere is this idea that if you've identified a, quote, mechanical ground level fall, that this is not something worthy of further exploration, and we'll talk about what more can be done to prevent further falls in these patients. And then I'll spend one slide briefly talking about how to prevent bone fall-related injuries and who would benefit from a screening DEXA. A lot of the tools that we'll talk about in this talk are borrowed directly from an excellent toolkit online provided by the CDC called STEADY. I'll show you the toolkit in a little bit, but again, our goals are to screen these patients at high risk, modify the risk factors that we can, and then intervene to improve outcomes for our patients. So the reason we care about this so much is that falls continue to be the leading cause of fatal and non-fatal injuries in all age brackets and is a leading cause of all-cause death in older adults. It'll be unsurprising for you to hear that the likelihood of injuries resulting from these falls increases with age. In the US, more than 1 in 4 adults fall every year, and this is incredibly burdensome to our healthcare system and quite expensive, and obviously for our patients, this is no good. 1 in 10 of these falls results in a serious injury, and by that I mean either a head injury or a broken bone. And then a lot of studies have shown that For various mechanisms, adults living with HIV experience a fall prevalence at earlier ages than people living without HIV. This one study that I've chosen that was published in 2012 showed that the prevalence of falls in patients living with HIV at the age of 52 paralleled that to adults more than 10 years later living without HIV. And what I hope you take away from this talk is that a lot of these falls are preventable, and I'm hoping to charge you forward with that mission. So very quickly, why this matters for our population. As you all know, patients with HIV manifest this accelerated aging phenomena, and there are a lot of comorbidities in this population that increase both the risk of falls and the risk of poor outcomes from falls. And so I've highlighted a few of those here. These patients are at higher risk for frailty with sarcopenia and low BMI. These patients can have neuropathy and lots of reasons for cognitive impairment as they age. And they're also at higher risk for polypharmacy. I see a couple of pharmacists on the chat, and so you know even better than us that these patients are taking a lot of medications in addition to their antiretrovirals. And many of these would be on the Beers criteria or in the high-risk category because of their effects on the cardiovascular and CNS systems. Guidelines for fall prevention in the general population is that all adults greater than 65 should be screened because we know that this fall risk happens earlier in patients with HIV. The official guideline is that these patients should be assessed for fall risk and frailty starting at age 50. And then patients for whom your spidey senses are going off, that this patient may be having difficulty with gait or balance and having falls, requires more advanced assessment. And this diagram here provided by the CDC, we see that this problem is going to continue to skyrocket as our patients are aging. Screening for falls is incredibly straightforward. The most evidence-based screening tool is simply asking patients whether they've had any falls in the past year. I think it's important to pause and think about what you're asking. What is a fall? And so I think because this can be embarrassing or stigmatizing for a lot of patients, and a lot of patients are worried about losing their independence, they may minimize their falls and saying like, oh, I didn't hit the ground, I fell into a chair, or I very gently lowered myself to the ground. And the key is that if it wasn't intentional and they had a change in their vertical position, then despite their clever descriptions of the falls, this is still something that we should be worried about. This really cool study published right here at the University of Washington a couple years ago showed that you can have a very sensitive screening tool for somebody who's at risk for falls, even if they haven't had any in the past year. And these are simple and they're self-reported and patient-centered. You can ask patients, do you feel unsteady when you're standing up or walking? Are you able to stand up without using your arms when you rise from a chair? And then do you worry about falling? We've shown again and again that being preoccupied with being afraid of falling itself increases your risk of falling. So a yes answer to any of these prompts further evaluation. Those of you who have worked with me in the clinic or in the hospital know that my brain refuses to work with mnemonics, but in case your brain is different than mine, here is a very well-known and fortunate or unfortunately titled, depending on your perspective, mnemonic to think about obtaining a history for someone who's had a fall. SPLAT. The S stands for symptoms that may clue you into the mechanism of the fall. Were they having dizziness beforehand? Did they have any vision changes? Did they feel like their legs simply gave out? The P is for previous falls, which again is what falls are you having, and can we identify a setting in which you are most at risk? The L for location. Does this person tripping over uneven sidewalks? Are there hazards in their home? Is this particularly a problem on stairs? The A is for activity. A lot of these things are behavioral. I know I'm certainly at risk for falling because I tend to be hurrying and rushing around. We have a patient that Dr. Thomas, who's on the line, and I are taking care of right now, who seems to fall over every time he challenges his center of gravity while reaching for items. Are they using a walker or cane? And if so, are they using it correctly? And then finally, the T is time of day. Does it have a relationship to their eating or drinking? Are they using substances like alcohol? If this patient has diabetes, this is something to really think about in time to temporally correlate with their eating and their medications. And then There's a concept of this long lie in which patients can suffer from injury if they are on the ground for longer than 5 minutes or otherwise unable to get up on their own. This can lead to things like rhabdo and precipitate more injury from their fall. This busy slide is the way that most geriatricians think about a person's fall risk. As with most syndromes, falls are generally multifactorial, and this depiction helps us chip away at modifiable risk factors. I hope you notice right away that some of these risk factors are more easily modifiable than others. I've kind of grouped them so the more easily targetable things are near the top and less easily targetable things are near the bottom. On the left in green, we have risk factors considered more intrinsic to the person themselves, such as deconditioning, sensory impairment, and neuromuscular problems. On the right in purple, we have extrinsic risk factors. We often hear, again, people minimize falls, insisting they merely tripped on a carpet or on one of Seattle's many uneven sidewalks. And I hope what you take away is that there are probably more risk factors at play. This person who tripped, could they have righted themselves after tripping if they had better core strength? Is their vision optimized to anticipate upcoming tripping hazards? Do they have difficulty flexing their hip or ankle to navigate their environment? And so this is a fairly intuitive slide. Our goals for treatment are to reduce people's chances of falling and to address the risk factors I've had on the previous slide. We'd like to reduce the risk of injury should they have a fall despite our best efforts. And then, again, in the service of what matters most, we'd like to preserve the highest level of independence and mobility for our patients. When we're talking about environmental and behavioral modifications, I mentioned that the CDC and also specifically Washington State fall prevention websites have excellent toolkits. This is one such screen grab from one of their toolkits. You can send your patients home with checklists like this to talk about risk factors and modifications they can make to their home to make it a little bit safer. You can also refer to occupational therapy, and they can go in and do an in-person home evaluation. It's also worth exploring whether patients have things that are probably unhelpful, like rushing or multitasking, when you're addressing modifiable things that they might be tripping over. This is the part where geriatricians shake their fists and talk about smartphones being distracting. When thinking about fall prevention, this is the money slide of my talk. I really want you to take away that an ounce of prevention is worth pounds and pounds of cure in this case. If your spidey senses are picking up that a patient is at risk for a fall or already having falls, it is pretty much never wrong to refer them to a geriatrician or other fall prevention experts like physical therapy. And if you're in Seattle, we have a falls prevention clinic at Harborview. All older adults need structured exercise to challenge their balance and work on their strength to combat age-related muscle loss and frailty and loss of endurance. Research shows that in order to reduce falls, exercise must focus on improving balance and strength. They must also be progressive, meaning to get harder over time, and practice for about 50 hours. So this means taking a 1-hour class at least 3 times a week for 4 months in order to really see a benefit. Tai Chi, I feel like every 5 minutes another study comes out that shows the benefit of Tai Chi for our older adults. Another study came out recently showing how it can improve sleep for patients who suffer from insomnia. And dozens of papers show that Tai Chi is a low impact and social and strength-based activity in order for patients to slowly challenge their balance, and it reduces their risk of falling. I encourage you to think with your care team and your pharmacists about the medications that may increase fall risk. And then again, I'd be so happy to see your patients in our clinic for a more comprehensive fall assessment. I thought this would be a good time to highlight the Washington State toolkit that I mentioned earlier. So hopefully this link works. This is the Washington State Fall Preventions page. They have lots and lots of resources. Hopefully you can see my cursor on the left. And then my favorite page on this toolkit is this evidence-based exercises class. There are so many in Washington State, and all of these, again, are evidence-based to challenge somebody's sense of balance and help them regain some strength. Something geriatricians do all the time is Google senior centers close to our patients to see whether they have Tai Chi classes or other fitness classes. And so I feel like they all have kitschy names. I, for one, really want to try Bingo Size. This is a exercise class that combines bingo and strength and mobility, and this sounds super fun. And then I would like to spend a few minutes talking about osteoporosis. The USPSTF recommends that older women above the age of 65 get a DEXA to look for osteoporosis, and they make no comment on whether men should or should not get a DEXA. The National Osteoporosis Foundation is more generous, and they recommend all postmenopausal women or men greater than 50 with other risk factors. And I hope to convince you that having HIV, even well-controlled HIV, should prompt this discussion. I will briefly say that, annoyingly, even though these are the recommendations, Medicare has not yet caught up, and so sometimes insurance coverage becomes an issue. And gosh, I wish I had an hour to talk about that. More and more data suggests that these age-related changes in bone density are accelerated in patients living with HIV compared to age-matched patients without HIV. And so in this study, we see an example of both accelerated and attenuated aging in patients living with HIV, meaning that bone mineral density loss and associated fracture risk happens both earlier and at a higher incidence in patients living with HIV than those who don't, again, even for those who are virally suppressed. There are so many hypothesized reasons for this, that the virus itself increases osteoclast activity and suppresses osteoblast activity, this chronic inflammatory state that we kind of blame for a lot of the syndromes associated with HIV, and then a lot of commonly used HIV medications, including protease inhibitors and infamously TDF, are associated with bone loss in themselves. Again, this could be a whole talk on its own, so I'll be brief. Part of reducing risk of fall-related injury is screening for osteoporosis, and we'd like to identify patients who are the best candidates for bone rebuilding therapy, like bisphosphonates, romosozumab, or PTH analogs. As mentioned, all postmenopausal women, I think, deserve a screening DEXA. Men above the age of 50 with additional risk factor also deserve a DEXA, and I hope that this slide will help you triage which patients are most at risk to prioritize these. There's something called a FRAX score, which if you obtain a DEXA, you will obtain a FRAX score in the report. But I hope that you know that you can also calculate a FRAX score manually without having a bone mineral density measurement. When you have these slides, this is a link that should bring you to the calculator, but Googling it also works. It'll ask you to fill out the patient's age, their gender, their weight, and then obviously if they've had a prior fracture, this automatically puts them at higher risk. And then I like that this calculator forces you to think about other risk factors for bone mineral density loss, like tobacco use, substantial alcohol use, chronic steroid use. Rheumatoid arthritis itself has a relationship with bone rebuilding. And then this cryptic secondary osteoporosis question. And so I dug into what kinds of things the folks that made the FRAX calculator consider a secondary osteoporosis. And they have highlighted type 1 diabetes, long untreated hyperthyroidism, low testosterone or estrogen states, and then chronic malnutrition, malabsorption, and chronic liver disease. HIV is missing, but I think in the next few years we will see HIV be added to this list for the reasons I mentioned a few slides ago. And so I think for these patients in which you're thinking that they're at high risk for falls or fracture, plugging in their numbers and seeing if you can talk yourself into obtaining a formal DEXA if you're on the fence. And then I would like to highlight that the DEXA will give you a T-score, and if it's negative, a smaller number than negative 2.5, that is diagnostic of osteoporosis and they warrant treatment. Even without the DEXA, if this calculator gives you a risk of a hip fracture greater than 3% or a major osteoporotic fracture anywhere greater than 10% over the next 10 years, and these are patients that are particularly at high risk for fracture and warrant a baseline DEXA and treatment. All patients, especially in cloudy Washington state, ought to have replete vitamin D, and that's greater than 30 nanograms per milliliter, and then encouraging that they're having the other building block important for healthy bone growth, which is calcium. And I generally encourage my patients to have at least 3 servings per day. And then again, in a research-rich setting like Seattle, we've got clinics to help you with that, and we would love to see your patients in our Healthy Bones clinic. With that, I have so many mentors that have taught me so much over the last 10 months, and lots of these folks work at Harborview's Healthy Bones clinic and our fall prevention clinic and our senior care clinic, and would love to meet our patients.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.